Hi everyone, and in this video I'll be discussing another topic, that is pharmacotherapy of osteoporosis. What do we mean by osteoporosis? The name itself is telling you. Osteo means bone, porous means the bone has become weak and fragile. Now the problem is when the bone is weak and fragile, even for a simple fall the patient will have fractures. Now who will suffer with osteoporosis? Usually a post-menopausal woman. The reason is once the menopause occurs, the estrogen level comes down and the bone becomes osteoporous. Another important reason is the aging process, what we call it as senile osteoporosis. The third important reason is the drug induced. That means when we use steroids for a very long period, steroid can also induce osteoporosis. Basically, to understand this topic, there are two important cells in the bone. The one which causes bone formation, it is called as osteoblast. The one which causes bone resorption, it is called as osteoclast. Now, usually they are in balance. The osteoblast will lay down the bone. Osteoclast will trim that so that the bone forms normally. So both are required for us. But the problem here in osteoporosis is the osteoclasts are hyperactive. They resorb the bone more. So our aim is to make osteoblast more active and suppress the osteoclastic activity. So that is what we do in osteoporosis. Let us understand what are the drugs used for osteoporosis. So osteoporosis, the name itself is telling you, osteo means bone and porosis means the bone has become porous, that means it is weak and fragile. So what is the problem if the bone is weak and fragile? So it is prone for fractures. The bone is prone to fractures. I told you there are two important types of cells. One is called osteoblast. Osteoblast is also required for bone formation. And one more cell is osteoclast. And osteoclast is the one responsible for bone resorption. So it is going to do bone resorption. Now, when we have to treat osteoporosis, what is our aim? The aim is simple. We have to increase the activity of bone formation, that is, which cell I should stimulate. Obviously, I have to stimulate osteoblast. And which cell I should decrease? I have to decrease the activity of osteoclast. So this is the management. Now, how do I manage and how do I understand this topic? For that, you need to understand some pathophysiology. So let us understand that and we will understand the targets of the drugs. So let us understand the pathophysiology of osteoporosis. Now, we know that for bone formation, we require vitamin D and we require calcium. Now, whenever the calcium comes down, so there is secretion of an hormone called parathormone. The hormone name is parathormone, and parathormone will act on a cell called, the cell name is osteoblast. So you are correct. It acts on the cell called osteoblast. And parathormone is made up of 1 to 84 amino acids. Now when it stimulates the osteoblast continuously, then the osteoblast will secrete a ligand, and that is called a rank ligand. It secretes a ligand called rank ligand. So that will be secreted, and this rank ligand will bind to the receptor which is present on the osteoclast. So there is a receptor for this. So this is the position where the rank ligand binds, and these cells are called as osteoclast. Now when these osteoclasts are activated, so we call it as activation of osteoclast. So when they are activated, they start resorbing the bone. So they start bone resorption. they start bone resorption, and when the bone resorption occurs, there is increase in calcium release. So this is just a simple pathophysiology. Now, what we need to do is we should not activate the osteoclast. Now, if the osteoclast gets activated, there is bone resorption. So let us understand what we can do in management of osteoporosis. Number one, I told you that vitamin D is most important for increasing the calcium and bone formation. So we need to give patient vitamin D supplementation. So the primary therapy for osteoporosis will be to supplement vitamin D also. Second, also we can give calcium supplementation. So we can give calcium supplementation to the patient. Yes, so we can give vitamin D and calcium. Nowadays they are available in combination therapy and doctors will prescribe. So that is strategy A, strategy B. And we can also give certain drug. Can you imagine there are certain diuretics which can increase the calcium? Is it loop or thiazide? Take a guess. Obviously they are thiazide diuretics, and you know that thiazide diuretics, they increase the calcium and they can be used for management of osteoporosis. And the thiazide diuretic what we use is hydrochlorothiazide. So it is called as hydrochlorothiazide. So we did vitamin D supplementation, we give calcium, and we use thiazide diuretics. Now they observed one more thing. If you give parathormone continuously, the osteoblast will release rank ligand and then activate osteoclast, which will lead to bone resorption. But one more thing is, if you give this parathormone intermittently, so if you give this parathormone intermittently, now this has shown to increase the activity of osteoblast, and that will increase bone formation. So please see this very carefully. If you give parathormone continuously, bone resorption occurs. If you give it intermittently, bone formation occurs by stimulating osteoblast activity. Now we have a recombinant parathormone. And it is made up of only 1 to 34 subunits. And that is the next target, and that is called as, the drug name is called teriparatide. The name is teriparatide. It's a recombinant parathormone, and we are giving it intermittently, and it increases osteoblast activity. The next one is, we can do one thing. You can block the rank ligand, and that is done by a monoclonal antibody that is called denosumab. So denosumab is a monoclonal antibody which blocks the rank ligand. If you block that, it will not be able to bind to osteoclast, and they will not become activated, and there is no bone resorption. Now, another important aspect what we can do is, we can stop the activation of osteoclast, and that is stopped by a group of drug called bisphosphonates. Now the bone resorption can also be stopped by another group of drugs, and that is called calcitonin, and one more group, they are called as SERM, and the name of the SERM is called relaxifen. So you understood the pathophysiology here. First we give vitamin D supplementation, calcium supplementation, that is common. Along with that, thiazide diuretics, because they increase calcium. Then what we can do is, we can give recombinant parathormone, but it has to be given intermittently, so it increases bone formation. Another thing is, you can block the rank ligand. It is done by denosumab, or you can inhibit the osteoclast activation by giving bisphosphonates, and you can inhibit bone resorption by using calcitonin and a serum called relaxifen. So we understood the drug targets. Now let me approach in one more manner. Now what is our purpose in management of osteoporosis? Our purpose is to increase the activity of osteoblast and to decrease the activity of osteoclast. Now, who will increase the activity of osteoblast? It's nothing but the drug such as teriparatide. The name is teriparatide, and similar to that, we have another drug called abaloparatide. So these drugs increase the activity of osteoblast. Now we have a drug which can do both. And what is it called? It can increase the activity of osteoblast and decrease the activity of osteoclast. The name is called strontium ranelate, and it is called as dual acting agent. Now rest all what we have written the target. For example, the bisphosphonates. BPN stands for bisphosphonate, then denosumab, then the calcitonin, and then raloxifene. So these drugs suppress the activity of osteoclast, very much important. So in one of your recent exams, they had asked this question: which drug increases bone formation or anabolic effect? Is teriparatide was in the option. Remember, other drugs mainly decrease the activity of osteoclast, that is bisphosphonate, denosumab, calcitonin, and raloxifene. And the dual acting agent is called strontium ranelate. So we'll discuss one by one now. So the first one which we are going to discuss is the recombinant parathormone, which is made up of 1 to 34 amino acids. So it's not a complete parathormone unit, and the name is called teriparatide. And as the name ends with tide, it cannot be given oral. Obviously, it has to be given subcutaneous. And since it's formed the bone, it is called as anabolic agent. The meaning of anabolic agent is it forms the bone. So it is also called as the bone forming agent. Now, how do I give this drug? Should I give it continuously? No. It is given intermittent. So intermittently it is given. Intermittent administration. So where to use it? Now this drug is used only in severe cases. It is used for severe cases of osteoporosis. What is the adverse effect? The adverse effect is, since it's a parathormone derivative, what is the role of parathormone? Parathormone is known to cause hypercalcemia, so these drugs can also increase hypercalcemia. Second important aspect is they can increase the risk of osteosarcoma. So osteosarcoma is going to increase. Why? Because you are increase the activity of osteoblast, you are stimulating the bone. So will it occur for 1 or 2 days? No. If you are using it for more than 2 years of usage, then it will increase the risk. So it will increase the risk of osteosarcoma if you are using it for more than 2 years. So that warning has been given. That warning is called black box warning. Black box warning is been issued for teriparatide, telling that if you are using it for more than 2 years, there is a risk of osteosarcoma. So that's the reason why it is approved only in the case of severe osteoporosis, not for mild to moderate cases. So don't begin with that. Similar to that, we have another recombinant parathormone drug, a new drug called abaloparatide. So similar to that, a new drug, and it's also recombinant parathormone. The name is abaloparatide. So once we discussed this drug, let us move on to the next one. And that is called denosumab. Now you know that any drug ending with MAB is a monoclonal antibody, O for osteo. Now it's a MAB against What ligand? It's against the rank ligand. So it will not allow the rank ligand to bind and activate osteoclast. Now it's a mAb, obviously it's not given orally, remember that. And it is used in severe osteoporosis. So it is used for mainly severe osteoporosis, and the adverse effect what we see is hypocalcemia. Hypocalcemia. Because if you don't activate the osteoclast, they will not go and erode the bone. Because when you erode the bone, the calcium level increases. So that's why denosumab can cause hypocalcemia. Moving on to the next drug, and they are called as bisphosphonates. Bisphosphonates. Now, bisphosphonates are very much important, and we will be writing it as BPNs. Now, let us write certain bisphosphonates. Example is alendronate, residronate, palmidronate, and zolendronate. Now, please understand they all end with dronate, dronate, dronate. Zolendronate is also called as zolendroic acid. And this drug is given intravenous. Okay. Simply remember bisphosphonates, they end with dronates, and zolendronate is also called as zolendroic acid. Now, let us understand the mechanism of action. How do they work? Mechanism of action, remember, number one, they inhibit osteoclast activation. So they don't allow the osteoclast to get activated. So they inhibit osteoclast activation. That is point number one. Point number two, they cause osteoclast apoptosis. Then another important, they inhibit one enzyme that is called farnesyl pyrophosphate. So they inhibit an enzyme called farnesyl pyrophosphate, and this enzyme is important enzyme in mevalonate pathway. And mevalonate pathway is important for survival of osteoclast. This is required for survival of osteoclast, because we know that mevalonate pathway is required for cholesterol. And the most important enzyme here is farnesyl pyrophosphate, and that is important in mevalonate pathway. If you block that, the survival of osteoclast will not be there. So this was a question asked in your exam, please mark. So bisphosphonates have additional property to inhibit farnesyl pyrophosphate, a vital enzyme in mevalonate pathway. Clear? So once we understand the mechanism of action, let us understand the uses. So where do I use it? Obviously, what topic are we discussing is osteoporosis. So these are the drug of choice for any kind of osteoporosis. Any kind of osteoporosis, these are the drug of choice. So what are the type of osteoporosis we see? I told you, basically the senile because of aging process, then postmenopausal because of decrease in estrogen as they attain the menopause, and drug induced, particularly steroid induced osteoporosis. So for all this, these are the drug of choice. The next important use of them is they are used in hypercalcemia of malignancy. Hypercalcemia of malignancy. So it's a complication in cancers and the calcium level goes up. Now, whenever the hypercalcemic malignancy occurs, we have three important therapies. One is we give calcitonin. Now, calcitonin has fast onset of action, so that can decrease the calcium faster. Then we can also use loop diuretics. We know that loop loses calcium. Example is the furosemide. Now again we have the bisphosphonates which are also used for hypercalcemia malignancy, but they don't act faster, they have slow onset of action. So we use three important drugs in management of hypercalcemia malignancy. Number one, calcitonin, loop diuretics, and bisphosphonate. Fast onset is calcitonin, slow onset is bisphosphonate. Next, the third important use of the drugs are Paget's disease of the bone. So, Paget's disease of bone. Now, you know that Paget disease of the bone, there is osteolysis. Then, who will do the osteolysis? Obviously, osteoclast. So, if I suppress the osteoclast, the osteolysis will not occur. So, we can use it in Paget's disease of the bone. Another important is osteolytic bone metastasis. Osteolytic bone metastasis. Now you know that cancers can metastasize to some other places. Particularly if you take an example of breast cancer, it may metastasize to the bone. If it metastasizes to the bone, what happens? The osteoclasts get activated, they start eroding the bone, and the bone becomes porous and increase the risk of fracture. So these are the four important uses of the drugs bisphosphonate. They are the drug of choice for any kind of osteoporosis. They are used in hypercalcemia of malignancy, Paget disease of the bone, and osteolytic bone metastasis. So once we have understood the uses, what are the adverse effects of these drugs called bisphosphonates? The adverse effect of these are many a times we give these drugs oral. When we give this drug oral, they are known to produce gastritis. Not only gastritis, they can also produce esophagitis. So when we give this drug, there are two important complications, gastritis and esophagitis. Now what is the method to avoid this problem? To avoid this gastritis and esophagitis, what is the instruction you want to give to the patient is a question asked. Instruction number one, these bisphosphonate when you take orally should be taken at empty stomach. So patient should be taking this at empty stomach. Second, after taking the tablet, now before that I just want to tell you, you have to take the tablet with full glass of water. So full glass of water, it has to be taken. Now the important thing is when you take the tablet, after that don't lie down. Tell the patient don't lie down for 30 minutes. For 30 minutes. The reason is if they take the tablet and take a full glass of water and lie down, the drug will come back and start irritating the esophagus. So that's the reason you should not tell the patient to lie down for 30 minutes after taking the tablet. Another important is no food or beverages for 30 minutes. So after taking the tablet, patient should not consume any food or beverage up to 30 minutes. These are the things to avoid the complication, that is gastritis as well as esophagitis, most important thing. Now another important problem what we see is when we give the drug zoledronate IV. So when we give the drug zoledronate IV, it can cause two important reactions. The infusion reaction. So infusion reaction is nothing but when we give that IV, patient will have chills and fever. That's called infusion reaction. Second, the drug zoledronate can cause nephrotoxicity. So this is with zoledronate especially. Now moving on to the other important adverse effect. They can produce osteonecrosis of jawbone. Osteonecrosis of jawbone. Another important problem is if you are using it for more than 5 years, use of bisphosphonates. Now when you use them for more than 5 years, they increase the risk of fracture. And particularly they have shown to increase the risk of intertrochanteric fractures. You may ask a question, sir, we are using this drug to prevent fracture, then why the fracture is occurring? Now please understand, I told you in the beginning of the class that the osteoclast and osteoblast are required. They are in balance. Who will form the bone? Osteoblast. Who will resolve the bone? Osteoclast. Now, what you have done, you have suppressed the activity of osteoclast for so many 5 years. And who is growing the bone? Osteoblast. And the bone is growing abnormally. So nobody is there to trim it. And because of this imbalance, so bone is not going properly, and there is a risk. I am not telling fracture will occur, but there is a risk if you are using it for more than 5 years. So it has to be used less than 5 years. That is the meaning of it. So guys, these are the adverse effect when you take orally. This is the problem. IV, zoledronate, and osteonecrosis of jawbone, and more than 5 years of usage, it causes increased risk of fracture. And obviously, they are used in hypercalcemia of malignancy. What will they do with calcium? They can cause hypocalcemia. So the drugs can cause hypocalcemia. So that is about bisphosphonates. So once we are done with bisphosphonate, let us move on to the next target. The next target what we are going to discuss is calcitonin. So there are two derivations of calcitonin. One is the human calcitonin and salmon calcitonin. So salmon calcitonin is more potent compared to human calcitonin. Now this calcitonin, we can use it in the management of number one, hypercalcemia. So it is used in the management of hypercalcemia. Second, it is used for osteoporosis. Particularly, this calcitonin is used as nasal spray. So the nasal spray is used for which osteoporosis? It is mainly used for post-menopausal osteoporosis. So that is about the drug calcitonin. Now another drug which is used, and that is called SERM. SERM stands for selective estrogen receptor modulator, and the name is called roloxifene. So roloxifene is used for which osteoporosis? If they ask you, it is used for mainly post-menopausal osteoporosis. So we'll be discussing the roloxifene concept in the female sex hormones. So right now, remember we use a SERM called roloxifene in post-menopausal osteoporosis. So once we are done with that, are there any newer drug which have come for osteoporosis? Yes, there is some new drug available for osteoporosis. What are those? Now, osteocyte in the bone, it secretes sclerostin. Now, what is the role of sclerostin? Is to inhibit the activity of osteoblast, and it stimulates osteoclast. So the meaning is it is trying to cause the bone resorption because it is inhibiting the osteoblast and stimulating osteoclast. So the scientists thought, why don't we block the activity of sclerostin? So the name of the drug which blocks it is called romosozumab. So romosozumab is the one which targets and blocks sclerostin activity. So by blocking sclerostin, it has dual action. The dual action is number one, it increases the activity of osteoblast and decreases the activity of osteoclast. But mainly the drug has the anabolic action, that is bone forming action. So the name is called romosozumab and it's a new drug. So let us summarize the things about osteoporosis. Basically, osteoporosis, we need to do two things. One is increase the bone formation, decrease the bone resorption. The drug which increases bone formation is a drug teriparatide and abaloparatide. They have paratide in their name and they increase the activity of osteoblast. But they should not be used for more than 2 years. There is a risk of osteosarcoma and we use them for severe cases only. There is a drug which can have dual action, that is called strontium ranelate. And the drugs which suppress the activity of osteoclast are bisphosphonate, and they are the drug of choice for osteoporosis, any kind. And they mainly act by inhibiting osteoclast activation, and they are also used for hypercalcemia of malignancy. You should not use them for more than 5 years, they can increase the risk of fractures. Then we have denosumab, which targets rank ligand. Then we have intranasal calcitonin given for postmenopausal osteoporosis. One more drug for postmenopausal osteoporosis is called raloxifene. Then we have a new drug which blocks the activity of sclerostin, that is called romosumab. So that is about pharmacotherapy of osteoporosis. Thank you all.